All right. As Andrea said, I'm Dr. Karen Ardis. I'm the medical director at the Wound Center upstairs. We were open a year in October, and we have had great success up there. Wonderful healing rates. We've been able to do a lot of good work. So I appreciate y'all coming today to hear about what it is that we do up there. When I went to medical school, I don't think there were any wound centers in the country, and that wasn't that many years ago. Why do we have needs for wound care centers? Well, we're living longer. This is a good thing. But I don't need to tell any of y'all that, you know, things kind of break down as you get older. Things don't hold up all the way across the board. That impairs your rate of healing. Higher risk of diabetes, higher rates of diabetes as you get older. Diabetes, as we all know, causes problems with wound healing. Chronic diseases, mostly cardiovascular diseases, also impairs your ability to heal wounds. And obesity, the more flesh you have between your blood vessels and the skin, the harder it has to work for the blood and the healing factors to get out there and take care of things. So we got higher rates of chronic wounds than we did 50 years ago. So what is specialized wound care? Why do we have wound centers? We are evidence-based centers that do nothing but wound care. We don't manage, we address and refer out and manage and try to optimize all of the things that could impair your wound from healing, such as diabetes, such as vascular disease, and you'll see that on the slide coming up here. So what sort of stuff do we treat there? Diabetic wounds is our biggest deal up there. Venous stasis wounds, people that I'm sure you know them, maybe even some of you are here, that have chronic swelling in your lower extremities. All that chronic swelling, all that extra fluid and space between your blood vessels and your skin puts pressure on it. You get very shallow, very superficial wounds, but they do break down. And that is something that we can manage very effectively up there. The things in the middle, the osteoradionecrosis, delayed tissue radiation damage, people who have had radiation treatments for cancers in the past, 6 years to 40 years later, you can get tissue breakdown from that radiation, and we can manage that up there with the treatment that we do at the Wound Center, hyperbaric oxygen, and we'll talk about that in a bit. Same thing with osteomyelitis. That's a chronic infection in the bone. Surgical wounds, you'll see a picture of a surgical wound that had opened up and had not healed back up again. And a neuropathic ulcer, that's where you have loss of feeling in a body part, either from a spinal cord injury or diabetes, and because of that you end up with a wear spot on the skin. So those are the things that we take care of up there. So what is a chronic wound? This is another big eye-opening thing for me. I used to think a chronic wound was something that you had for 6 months, a year. Chronic wound, by definition, is something that has not started to heal within 2 weeks. I mean, think back to when you were 20 and you got an injury. That wound was gone in 2 weeks' time. Everything was optimized and working the way it needed to be working. If it has not started to heal within 2 weeks or not completely healed within 6 weeks, that classifies as a chronic wound. We see people that have been wandering around with wounds for years, some even decades. I mean, it just boggles my mind that there are people walking around with holes in their body that they've just somehow managed to deal with. And then look at the picture down at the bottom. This is a patient on the initial visit. This is on the side of the foot, right next to the big toe. This is at visit number 1, and this is 12 weeks later. This wound has been there for a long time, and just getting all of the pieces and parts working together the way they're supposed to be working, we can get these things healed. So, talked about why do we have wound care centers. Problem wounds, chronic wounds, not a large percentage of people, only 1 to 2% of the population, but population being what it is, that's a lot of people. 6.5 million people have chronic wounds. A lot of money spent on chronic wounds and on wound care products, a lot of outpatient procedures, a lot of hospitalizations, a lot of surgical procedures, and then skin scarring that is left over from wounds that were not managed to heal appropriately. Then we end up with scarring after that that may need additional care. Comorbidities, we talked about, other things that you may have that will impair your ability to heal. peripheral arterial disease. 15 to 20% of the population over age 65 has some sort of vascular disease, peripheral arterial disease. You know, we all know about people that may have had a cardiac stent, or may have had a carotid stent, or may have something done. We have to realize it's a closed system in here. So if you got a blockage one place, you're very likely to have a blockage someplace else. But just like if you have a blockage in your ticker and you don't know it till you get real bad indigestion one day, you may not know that you got a blockage in your leg until you have a wound that doesn't heal, or worse yet, till you show up with black toes, and that's not where anybody wants to be. Obesity, I don't need to tell you all about this. I'm in the same boat with the rest of y'all. We're all overweight. Not all of us, but a large portion of us are overweight, and that also causes problems with wounds. Diabetes, this is where the real bread and butter is. It says 7.8% of the U.S. population. We think it's probably closer to 10 to 12%, just these people haven't been diagnosed. This is not news to any of us that diabetes causes problems with wound healing. 25% of all diabetics will develop an ulcer or a wound during their lifetime. 5% annually, and 1% of them require amputation. And that's not something we ever want to do. We strive very hard when people walk through the door of the wound care center. Our goal is to get you and all your body parts across the pearly gates at the same time. So it is extremely expensive. I mean, an amputation costs a ton of money. You know, almost 40 grand for an amputation, $3 billion annually, and that doesn't count the rehab, the prosthesis, the decreased quality of life, and everything else that goes along with an amputation. And even if it's just a little toe, it's still a piece of you that impairs the way that you walk, it changes your gait, and it has serious trickle-down effects. So the average cost per ulcer episode for a diabetic wound is about $8,000 to heal a diabetic wound, which is a lot of money, but it's a whole lot less than an amputation, which is where they end up going. $17,000 if it's infected. $45,000 if an amputation is required, then all of the other stuff that goes along with that. So this is one of the wounds, a patient that we had up in the center. This was a patient that had had an abdominal procedure, a liver transplant. The surgical wound across the top of his belly here opened back up, had a little teeny hole. The doctor, his surgeon, tried to repair it. It didn't repair. He tried to stitch it together. Then he tried to cut out a bigger area and stitch that together, and it just kept growing and growing. This fellow was a little large in the middle, so he had some extra pressure on it as well. By the time I saw him, he had had this open for 2 years. Had not been able to get in the pool with his kids. His wife refused to look at his abdomen, much less touch him. She was terrified of this. She was really grossed out by it. And he was preparing to have a skin graft done, which with his other problems would have been an inpatient stay, taking a graft from someplace else, and he was really not looking forward to that. He managed to make through the front doors, and you can see from March to July, we got him healed up. No skin graft, no inpatient stay, no additional surgery. His wife was happier than he was, let me tell you. I think we missed a piece right before that. Where's the other one? She stuck it in the wrong spot. We're missing a wound. Well, we had a picture before this to show you that along the line here, you can see this line right along the middle here. This patient had a big surgical scar along the side of her leg there, and when she came in, the spot only looked a little bit bigger than that, but the actual wound was this huge cavity that was underneath of it, and that's one of the first things that we do is to see what the extent of the wound is. If you got all this gunky stuff on top of it, that's not good tissue, it's not going to heal. So the first thing we do is get it cleaned out and then heal up. But it looks like we deleted that picture. But there it is, healed up. It did really good. This is a diabetic patient who had had this wound for years and years and years, I think 3 or 4 years. A lot of complications going on here. You can see she's already lost some toes. The foot has changed in architecture. She's walking on the side of her foot. We've got some mobility issues. This has been a long process with her, but you can see here in 5 months' time we've made significant progress there with the wound. This is somebody, a diabetic, who had had a skin graft, who's also got vascular disease. This is initial wounds when she came in October, and here we are in February. Again, not healed, but much, much smaller. Very challenging patient. Why do we worry about amputations? Amputations has a huge mortality rate. If you get lung cancer or pancreatic cancer, your 5-year mortality rate is higher than it is for an amputation. But if you have an amputation, your 5-year mortality rate is higher than it is for Hodgkin's disease or for prostate cancer or breast cancer. Now, cutting a body part off doesn't make you die, but typically it's the end of the road. I mean, it's a manifestation of everything else that's going on, and that's why we like to get these patients as soon as we can to prevent it to progressing to this point and trying to fix all of the other pieces that are broken so that they don't progress to amputation. 30% of chronic wounds left untreated result in an amputation, and almost 50% of those patients will die within 5 years. Survival rates after amputation, lifetime risk for foot ulcers and diabetes is about 15%. And there's your mortality rates. You can see they're pretty high. Contralateral means the other side. So if you've had one amputation, 56% of patients have an amputation on the other side within 3 to 5 years after the first amputation. Very, very upsetting statistics. So what do we do up there? It's not just me and a nurse up there trying to figure out what to do and trying to cure all the problems of a patient. We have the patient, we have the wound center staff, and we coordinate whatever needs to be done with all of these other specialists, and other specialists that aren't up there. We send a lot of patients to the vascular surgeons. We find vascular problems that people may not know that they have, and can get them opened up. We had a patient not too long ago who came in with a wound on her right leg. The first thing we do on everybody is check for blood flow. Her blood flow didn't look good on her left leg. She had not a problem in the world with it. We sent her down and got official studies done. She had a 99% blockage in her left leg. We sent her over to the vascular surgeon. They did an outpatient procedure. She now has full blood flow in her leg. I mean, and that just really made me happy. You know, she didn't have any problems, but if she didn't have that wound, she would have been one of these people that show up with black toes one day, have no symptoms until that 99% goes to 100%. Pulmonary general surgeon, ENT, infectious disease, and your primary care provider. We are constantly sending patients back to their primary care provider for improved management of their blood pressure, of their blood sugar. We work with the diabetic educator. We work with the podiatrist. We send people all sorts of places to try to get them optimized. So, what do? We talked about we have a systematic approach. The first thing we do is look for blood flow. The wound's not going to heal no matter what we do if you don't have enough blood flow. And then we make referrals off. If there's a fixable problem, we work to get it fixed. Get rid of the dead tissue, get rid of infection, help with the excess swelling and the fluid. All of these things will cause problems with delayed wound healing. Get the blood sugars under control. And then we do tissue grafts. Generally not your own skin graft, since that's a pretty major surgical procedure, but we have bioengineered tissue, skin, and skin products that we will use to heal wounds up as well if we get that far down the pathway. And getting the pressure off of it. All diabetics should be, especially if you got a foot wound, diabetic shoes, inserts, taking the pressure off. We cast some people as well and had great success. We also might do hyperbaric oxygen therapy, and we'll talk about that in a little bit. That's a very small percentage of our patients. Surgical debridement, getting all the gunk off of there. Wound vacs, negative pressure debridement. We actually have this really cool device. We put it on there and seal it up over the wound, and then turn on this little machine pack that they carry around, and it's like a vacuum, and it sucks on the wound all the time. And it sucks all the gunk out of there, and it stimulates all of the cells and the tissues to grow and close together, and it's pretty nifty. Wrapping and compression therapy for the swelling that we talked about previously, that's just like a miracle. And then opening up and getting rid of the junk on there. Biopsies, we've had more than a few patients that come in with a non-healing wound that turns out to be a cancer that nobody's bothered to biopsy. Again, we check for vascular stuff, venous or arterial. We talked about the skin grafting, edema management, etc. We work with our vascular lab here at Easley. Occasionally there are things that they need to go to the vascular surgeon or the vascular lab in Greenville. If it's a specialized test, we're able to manage most of the stuff that we need to here at this facility. Hyperbaric oxygen therapy, there's a patient in a hyperbaric oxygen chamber. This is oxygen, 100% oxygen at increased pressure. Kind of feels like when you're going up in the mountains or when you're scuba diving, you get a little increased pressure in your ears. That's the amount of pressure it is. It's not massive amount, it's like twice the amount of normal atmospheric pressure, but that helps to get extra oxygen into the tissues and into the plasma around the tissues, stimulate healing, stimulate the white blood cells and all the growth factors that need to go along to get this taken care of and get the oxygen down to the tissues that need the oxygen to heal. As I mentioned, this is only for a very small percentage of people. The acute stuff we don't do upstairs since we are outpatient chronic. So acute traumatic and acute peripheral, those would be at an inpatient hyperbaric center like in Greenville or Spartanburg. But the chronic stuff, diabetic foot wounds that are down to the bone with infection, radiation injuries to the skin and bones and soft tissues, skin grafts, and chronic infections or progressive necrotizing infections. Those are generally inpatient, those skin flesh-eating bacteria that we all heard about last year. And I think it says down there, 94% of diabetic ulcer patients treated with hyperbaric oxygen therapy still have their limb 55 months later. Good news. And although you may have heard about somebody trying hyperbarics for Alzheimer's or stroke or Parkinson's, that's all really, really interesting research, but it's just research. And it is not something that anybody's going to pay for and not something that we're going to do as a non-approved indication right now. You know, it's possible that in another 20 or 30 years that they may have done enough research to see that it's valid and gives long-term benefits for these people. If you think about it, it makes sense, but we follow strictly what the Medicare guidelines are. So what are clinical practice guidelines? This is stuff that the Institute of Medicine has come out as practice parameters that are supposed to assist patients and practitioners in making clinical decisions and to ensure quality of care across the continuum. And this is how we manage all wound center patients. We have this poster up on the wall upstairs. Y'all can't read all of this, but each of those little boxes up there has a number on it, and then this number goes to another flow chart and goes to another flow chart and another flow chart. So it's not idiot proof, but it certainly guides me to know what I need to do. And it also keeps me from starting treatment here if I haven't taken care of the first problem up here. And the first thing up there is to evaluate for blood flow. Got to have blood flow down, got to have blood flow going back. And sometimes you have things that are not fixable, but we need to identify what is fixable and what's not, and then work within the parameters that we have. So, who can benefit from specialized wound care? Again, patient that has a wound that has not made progress to heal within 2 weeks. This says 4 weeks, the other one says 6 weeks. There will not be an entrance exam. You can just call and we'll see you if you need to. So, to schedule an appointment, you can call. You can get a referral from any physician. We have dentists and cardiologists send people in as well. But no referral is necessary to schedule an appointment. So, you know, we have patients that call themselves. We have one lady who said she was walking down the street in her capris and had a bandage on her shin, and one of our former patients said, "Hey, you need to go to the wound center." And she saw her bandage and sent her on up there. So no referral is needed to schedule an appointment. We do keep in very close contact with your primary care provider, with your cardiologist, with your surgeon, with anybody else who needs to know that you're there. Our job is not to manage all of the other medical problems, but to make sure that you're getting the care that you need for those problems while we're managing your wound. And on top of all that, insurance pre-certification will be taken care of by Erin, our front office Wonder Woman, and she communicates with you very clearly. The last thing we want is for you to get a surprise after a month, an ugly surprise after a month that you didn't know was coming. So she does a very good job of insurance pre-certification. So here we all are. Myself, Dr. Wheeler, who's one of Easley general surgeons, works over at the facility. Dr. Wilson is also a family physician. He works at the facility, as does Dr. Beasley, a family physician. All of us have gone through extensive, intensive, specialized wound care training over and above our normal education to get onto staff here and to be able to do this. And then we have our program manager and then several RNs that help, and they have also been through specialized wound training, and Erin, our one-to-woman up front as well. And that's it. Sorry if that was quick, but wanted to get it out. Okay. Questions?